managing heaven. Right finger. The high five.
Thank you very much, especially to Dr. Avadin and also Egyptian Ophthalmological Society. It's my first time here. I'm really enjoying it. So the title of this talk is High Fives in Cataract. So these are my financial disclosures. Yeah. It's okay. Yeah. Nothing related to pediatric cataract. Usually we don't have any financial disclosure. So when you see a pediatric cataract, there are different types. As we discussed, 6 to 7 types of pediatric cataract right now we discussed. I'm going to discuss these 5 when it is microcornea, in the presence of anterior segment dysmorphology, when there is posterior capsular plaque, and what do you do in infantile cataract and ROP cataract. The first one is about microcornea. You can see this patient has a peripapillary rough. Microcornea with peripapillary rough with microphakia is a sign of Loeys syndrome. This pupil will not dilate whatever you do. This patient, meiotic people, really requires long-term dilatation. That's why we are doing a pupilloplasty using a vitrector in this patient. And you can see this lens diameter is very small. Microphakia, microcornea, meiotic pupil is a very, very significant sign of Loeys syndrome. Why we need to know? Because they may have a delayed anesthesia recovery because their diaphragm muscles are very weak. So we have to be very careful, and this is how it really helps to understand. And obviously no point in putting a lens here, and you can see in spite of that 4 or 5 millimeter of the cornea, eventually with the glasses they do very well. They will be able to do most of their things over a period of time. So sometimes, in spite of using intracameral epinephrine or phenocane, it may not dilate. In those kind of situations, you have to use iris hooks. They are not so difficult to use. And once you really dilate it with the iris hooks, you can see the morphology of the cataract. Till then, it looks like a very insignificant cataract. Now you can see in this patient there is no microphthalmia, there is no microphakia, pupils are meiotic, that's it. And once you remove the cataract, you can see there is a plaque here. This plaque was fibrotic and it was attached. So once you implant this in the back, most often back is the best place for intraocular lens implantation in children, and you can see they are very adherent, so you can slowly remove those and then put the lens, put the sutures there. So that's about the non-dilating. Sometimes you will have this corneal opacity and also cataract like this. One thing you need to do here is use a viscoelastic and do not try to remove that. You just cut the adhesion between the lens and the cornea, because if you try to remove it, it can really cause endothelial damage. So let's look at, this is 5 or 6 already there in this particular paper. You can see this is one of the PHPV, and more recently it's called PFV, that is persistent fetal vasculature. Always try to do all the gonioscopy and other things, and you can see here there is a big vessel coming from here. So you can also see these ciliary vessels. There is no doubt that this is PFV. What you have to do for this is use this endocautery. The retinal surgeons use it. You can cauterize this before you go ahead with the capsulorhexis. Probably in this patient, everything is fused here. It's a membranous cataract. And once you do that all around 360 degrees, you try to remove this with the vitrector. Sometimes it may not cut. That's why we have to use a myringotomy knife to make an opening. You can see here, using of meningotomy knife or side port knife along with this curved scissor really helps. And once you have done that, then you can remove all those curds. There is two things are there. When it is too much intact, probably sometimes we may not be able to remove this. It causes a lot of disturbance. And in some cases of PFV like this, you can implant a lens depending upon the corneal as well as lens diameter. When there is a plaque like this, you can see here, the plaque can come with the Stinsky hook. This is not fibrotic. It's fibrotic, but it is not attached to the posterior capsule and it's not together. So you need to use this separator, and you can use this as much as possible because you can debulk it. But still you can see the last part is really not coming. So in that case, you can use this scissors to cut this, and rest of your surgery almost remains the same as regards to other surgeries. So infantile cataract, always there is a question whether you implant in babies or not. This is the Venn diagram where I use preoperative factors, intraoperative factors, and socioeconomic factors. Depending upon this diagram, depending upon these factors, we try to implant a lens or not. For example, if the corneal diameter is less than 10.5 and the axial length is 18, probably we do not use it. But using this criterion, we are able to implant lens in 40 to 45% of the babies with cataract, as you can see the sequential surgeries. And sometimes immediately after surgery, you don't know how the patient's vision is. So we use this baby vision screener and pediatric perimeter to really see what is happening to the child in the immediate post-operative period. You can see this. These are all different quadrants. The lights are shown there, and the baby is underneath this. Can you see this? This is a system called babies. It's indigenously we developed it, and it really helps in patients with these kind of, that's the first video is just before surgery, and second video is after 1 week, and the third video you can see the lens is there, and then child is trying to see. This is as early as 3 weeks after cataract surgery. So that way these instruments really help to look at the progression. One thing I really want to stress is whoever is taking care of pediatric cataract, do a good follow-up. What do you mean by real follow-up? Because whatever surgery you do, unless you take care, refraction, eye pressure, alignment, and the lens and the retinal status at every visit, that's called real follow-up of these patients are very, very much mandatory. Otherwise, in 10, 12 years, you might lose the eye to glaucoma, or maybe because of visual axis opacification and so on and so forth. That way, you can make sure that the child gets good vision. The last thing I just wanted to cover is the ROP. ROP cataracts can be because of the lens touch during the surgery. It can be because of the injection. As you can see here, in this patient, there is a plaque-like. We looked at that the baby was 800 grams, and now the child is almost 6 months of age. You can see the cataract capsulorhexis needs to be done, and then once you have done that, routine way of lens aspiration, it's not anything different. Only thing is you can put the lens also in these patients. Once you have done it, then you have to suture in these babies. And we also have looked at cataract surgery in retinopathy of prematurity. This is the series what we have published in VJO, and that can develop regardless of modality of intervention, and post-operative complications and the refractive changes, because sometimes we think that they have more myopic changes, but in whatever 4 or 5 years follow-up, what you have seen, this refractive changes even in patients with ROP cataracts are almost similar. Also, when you look at the suture, when you take this anti-segment OCT, your wound after cataract surgery, sometimes it can look hyper intense as they grow, and sometimes there could be a small gap. So you need to really look at how the wound is closing. That really helps. And also this is a publication where almost 25 complicated systems of pediatric cataract has been published. If you want, you can go through it. And the last thing I just wanted to show is, as a pediatric cataract surgeon, you always have to look at the retina immediately after surgery, especially in total cataracts. And this is the way you can do it. You can inject a air bubble, or you can see with the video, you can see this is injecting air bubble, and this is without air bubble. You can see almost everything, especially in a post-operative cataract, total cataract. If you want to tell the parents this is the good prognosis, it really helps in most of. And it's cheap. You don't have to spend anything. Just with the air bubble, you can do it. Thank you so much, everyone.